This is an orthokeratology case where the patient is noticing that vision quickly regresses after about an hour of removing lenses. And we have pre and post-row topographies. The post-row topographies actually look pretty good. Centration is not bad, and we have huge treatment zones, especially for wave lens, which is pretty good. It's a little bit loose in the periphery, I think, especially in the right eye, maybe in the left eye too. The baseline topographies show some irregularities, especially in the visual axis. I don't know if that's because the patient maybe moved right when the image was captured, or maybe there's a poor tear film. I think this is a previous soft contact lens wear. But the patient's complaint with vision could be influenced by tear quality, definitely, both in terms of treatment as well as post-lens wear vision. If we look at the lenses, this is what the patient is wearing, and we've got asphericity built into the lens. I'm guessing this was to give ourselves a larger treatment zone, and we definitely accomplished that, but the patient is regressing too quickly. A couple other comments I would point out before we get into modifying the lens is the patient has, with the rule, corneal astigmatism, but against the rule, refractive astigmatism. So if this is not a tear film issue, I guess there's a fair amount of internal cylinder, and that will actually be worse after ortho K, and that can definitely contribute to poor vision after wearing the lenses. I believe the description in the support boxes also indicated that the vision wasn't really 20/20 even with the lenses on, and that's a little bit unusual. It could be the aspheric optics that's messing with vision a little bit, but I'm not really sure because aspheric back surface should be countered by a negatively aspheric tear film, which should get pretty good vision unless maybe it is the internal cylinder coming through and distorting vision a little bit. In either case, the refraction after removing lenses was very similar to the refraction prior to lenses, so I would at least build that into the lens. I'm not sure I'd go full 2 diopters more, but at least a diopter. So if our demand right now is about a 313, I would bump that up to about a 413 and at least check to see if that's giving us a little bit more headway into reducing refractive error. With orthokeratology, most of the regression does take place within the first 1 hour after lens wear, and then from that point on it should be stable for a good 10, 12, 14 hours. So if the patient is losing a lot of treatment during that first hour, that's not unusual. We just need to maybe potentially overcorrect by a little bit more than we are now. So I'd go ahead and just build in the diopter and shoot for a target of 413. And that's pretty close, and then double check in the meridians to see how our powers are, 54, 55, 56, and that's really uniform still. So that's good. We don't have to make too many changes in individual meridians. You'll notice that this does shrink the optic zone a little bit, and unfortunately that's just the nature of ortho K. More treatment means smaller treatment zone, but hopefully we'll still maintain enough room where the patient doesn't have too many issues with glare and halos at nighttime. I think we can do the same thing with the left lens, just build in another diopter to a diopter and a quarter and make sure we're headed in the right direction. If we wanted to, we could increase the sagittal depth of the lens a little bit in the periphery. What that will do is just to help smooth out these areas outside the treatment zone where we're not getting very uniform or even bearing. And even though the centration is not that bad, sometimes it's good to have the better seal off because that does enhance the treatment a little bit, get that tissue molding a little bit better. So some not too many changes I think need to be made to the lens. Hopefully this will get the patient on his or her way towards better vision. So best of luck. Thanks for watching.